Our next steps for small cell lung cancer really rely on developing biomarkers that has transformed our management for non-small cell lung cancer. We hope it will do the same for small cell lung cancer, but it's going to be very challenging. It's not the same types of markers. DNA testing, next generation sequencing doesn't really provide much benefit for small cell lung cancer. We know that we will see P53 mutations and RB mutations. We don't really have drugs for those. The use of PD-L1 has not been helpful for small cell lung cancer. The use of tumor mutational burden has not been helpful for small cell lung cancer. There are, we believe, certain subtypes, but they're not quite ready for use yet. They are based on differences in transcription, and we do think that we may be able to identify patients more likely to receive immune benefit, but we currently do not use biomarkers to give therapy. All patients should receive chemotherapy and immunotherapy as part of their initial treatment, at least until we understand this a bit more. One area of interest is the brain, and small cell lung cancer has a very high likelihood of spread to the brain. For example, for patients with limited stage small cell lung cancer, at least half of patients will develop brain metastases. The use of prophylactic radiation to the brain will reduce the risk of brain metastases. Initial studies, when lumped together, show that we drop the risk of brain metastases by about 45%. And initially that was thought to extend survival, but it does come at a cost. When we radiate the brain, there's an impact on neuropsychologic or cognitive function. This has been well studied in patients who had a complete response, but our current guidelines are to consider prophylactic cranial radiation after response in any stage. Again, giving prophylactic cranial radiation definitely decreases the risk of developing brain metastases. And the early studies suggested there was a small, about a 5% improvement in 3-year survival. But more recent studies conducted in Japan really call that into question. In this randomized study, which was done in the modern era, where we are now using MRI, which wasn't available in those older studies. In the MRI era, where we can monitor cancers more closely, when we can detect them more reliably, and in the era of newer radiation techniques to radiate brain metastases should they occur, question again, would giving prophylactic radiation really improve outcomes? And in this Japanese study, giving prophylactic cranial radiation after finishing chemotherapy did decrease the risk of brain metastases, but it did not improve survival or progression-free survival. In fact, numerically, survival was longer in people that did not get prophylactic cranial radiation. Now, this was for patients with advanced small cell lung cancer. For early stage small cell lung cancer, giving prophylactic cranial radiation is still standard, but I do think it's worth a discussion and really a shared decision-making model where we discuss patients' values and whether the benefit really outweighs the risk and toxicity of radiation in this setting. For advanced small cell lung cancer, we sometimes will deliver radiation to the chest. We'll call that consolidative thoracic radiation. And for patients who complete their initial chemotherapy, if they have residual disease in the chest cancer, we can still see on the scans delivering radiation to that site was associated with an improvement in long-term survival. It is not necessarily standard everywhere, but certainly worth a consideration in certain cases. We do not know if this applies when we're using immunotherapy, but that is the topic of an ongoing clinical trial. We have made progress in small cell lung cancer. Our current standard of care for extensive stage small cell lung cancer is giving chemotherapy with immunotherapy. The chemotherapy, carboplatin and etoposide. The immunotherapy agents, atezolizumab. More recently, studies of durvalumab showing similar outcomes. But giving immunotherapy with the initial chemotherapy improves survival. That is currently the standard of care, but certainly we need to do better. And ongoing trials are looking at adding more agents, other agents, or radiation in those settings to see if we can further improve outcomes and really establish long-term survival for more patients. This is an area where we really need to consider clinical trials as our preferred modality of treatment at any stage. In the future, we will get smaller. Biomarkers will transform how we treat small cell lung cancer. Newer, rationally designed drugs, again, available through clinical trials. But for today, it is chemoimmunotherapy as our preferred initial treatment for this highly lethal disease.